Good morning, good afternoon, and good evening, everyone. Thank you so much for joining us for today's webinar, which is titled Social Norms, Promoting Community Support for Family Planning. Let's go to the next slide, please. My name is Maria Augusta Carrasco, and I'm a behavioral scientist. I have been working in behavioral sciences for over 15 years, almost 20 years now. And currently, I work as the Senior Implementation Sciences Technical Advisor for the Office of Population and Reproductive Health at USAID. And in this role, I coordinate the work of the High Impact Practices in Family Planning, or HIPS. Today's webinar focuses on one of our more recent social and behavior change briefs, our brief on social norms. Next slide, please. Great. So very briefly, let's look at today's agenda. So I will give you a summary of what the HIPs are, and then we will move to look at the SBC overview brief. This initial presentation will be followed by my colleague Rebecca Langren, who will be presenting a summary of the norms brief for you. And then our colleague Mariam Diakite will be presenting an example of a social norms intervention from her experience. And we will leave approximately 15 to 20 minutes for questions at the end of our presentations. Let's go to the next slide, please. Before we begin, let's go through some logistical information. Please note that today's webinar will be recorded and posted on the HIPS website in due course. We will give you the link to the recording at the end of today's webinar. If you find this webinar helpful, please share it with colleagues. It's always helpful to listen to these webinars, I find. And as a note, please also look at some of the other webinars for these newer SBC briefs that are posted on our HIPS website. The other SBC briefs are knowledge, beliefs, attitudes, and self-efficacy, and a brief on couples communication. To download the handouts for today's brief, you can go to the command panel on the right side of the screen and click on the section labeled handouts. And additionally, if you want to ask any questions, please add them to the questions section in this webinar platform. And please go ahead and start recording your questions as soon as they come to your mind. Start adding those in so that we can have a very robust conversation at the end in the last 15 minutes of this webinar. Let's go to the next slide, please. All right, so very brief overview of the HIPS. What are the high impact practices in family planning? They are they are vetted evidence-based practices that are a summary, that include a summary of the literature, and then they also include some tips for implementation from experience. So in that sense, they serve for a purpose of research utilization, but then also a knowledge management purpose. And a key characteristic of the HIP briefs is that they are documented in an easy to use format. We keep the briefs at 8 pages so that busy decision makers and programmers and advocates can have time to look through these resources. You know, again, it's not a book, it's not a Bible, it's 8 pages, but they're packed with very helpful information. The criteria that is used to identify HIPs includes replicability, scalability, sustainability, cost effectiveness, and evidence of impact. So all of these high impact practices in family planning are practices that have proven to work to advance family planning outcomes. Next slide, please. We have 4 categories of HIP briefs, and they include the enabling environment, service delivery, social and behavior change, and enhancements. And the brief that we're discussing today is one of 6 social and behavior change briefs. In recent years, SBC programming for improved health has gained a lot more prominence than it used to have. And for example, you now see the WHO issuing a resolution supporting the use of behavioral sciences for better health. And we're also seeing the integration of SBC and behavioral considerations in areas where it was not very used in the past, in health areas not very used in the past. So this is very exciting, especially for those of us who are behavioral scientists, because we know that including behavioral considerations in programming is very important and helpful to reach the program goals. The need to ensure health programs include the SBC components has become more and more clear. And in fact, a testament to this is all of you who are participating in the webinar today. And we hope that for those of you who are new to SBC, you learned something about social and behavior change in today's webinar, particularly as related to norms, to addressing norms. And for those of you who have been working in this topic and in this area for many, many years, we hope that today's webinar gives you some new ideas of what else you could be doing in your programs. Next slide, please. In this slide, you will see a list of all of our HIP briefs in all of the 4 different areas. And one thing to note is that these are what our technical advisor group has identified as what works in family planning. It's important to note that this is not everything. We always, don't want to forget that there are other practices out there that would be important, but we often in the HIPS team, we think about, or initiative, we think about these practices as almost like the bread and butter, the basics that a strong family planning program should integrate. So again, not all of these need to integrate it, some of these, and that would depend on your context and the reality that you're working with. Next slide, please. Okay, so with that, we will go into the main course for today's webinar, which is looking at our social norms brief. And before we do that, I want to thank the authors of the brief that worked very hard over several months. It took over about a year and a half to come up with this brief, 8 pages, again, packed with a lot of thinking and a lot of very helpful information. And the writing team included Christine Galavotti, Jennifer Gales, Rebecca Lundgren, who's presenting today, Colin Zotieno, Shefa Skider, Caitlin Thistle, Claudia Brondrasek, apologies for my pronunciation, and Lucy Wilson. And I also want to thank all the experts that provided their comments during the public commenting period of this process. Next slide, please. Okay, so our colleague Joanna Skinner unfortunately wasn't able to make it today, so I'll be covering her slides. She's an expert in family planning, and you can hear from her as an expert in SBC programs for family planning. You can hear from her in our knowledge, beliefs, attitudes, and self-efficacy recording on our HIPS website. So again, apologies. We hope that Joanna feels better soon. So let's go to the next slide, please. All right. So, what is SBC? Social and behavior change, or SBC, is an evidence-driven approach to improve and sustain changes in behaviors, leading to improved health outcomes. SBC programs employ a deep understanding of human behavior from many fields, including communication, social psychology, anthropology, behavioral economics, sociology, human-centered design, and social marketing. And one thing we emphasize is behavioral folks like me like to emphasize is that it's not just communication. I know some of you may think it's just communication, but no, we have evolved over the years. We have gone from IEC materials, information, education, and communication materials, to a focus on primary communication, to now moving to other tools in our toolbox, which include behavioral economics, such as including incentives in the program, for example. So just very important to keep that in mind. It's not just communications. We have other tools in our toolbox. Next slide, please. Okay, so in this slide, you'll see the framework that is featured in our SBC overview brief, which again, you can find on our HIPS website. The SBC overview brief provides an integrated framework of how the 6 SBC briefs, HIP briefs, are related to each other. You can see the framework in this slide. On the right side of the framework, you see the HIP briefs that focus on channels of communication. Namely, we have 3 briefs focusing on channels: mass media, community group engagement, and digital health. And as you can imagine, these briefs were developed about 5 or so years ago when the focus was still on communication. But like I noted, we have evolved and in the field of SBC, and we now have moved beyond communication channels. Not only that, but we have learned that typically you just don't use one method of communication or one method of SBC to achieve your objectives of behavior change. It's better if you use more than one. So on the left side, the new briefs are focusing now on shining light on what are the behavioral factors that need to be addressed to reach your family planning program objectives. So as you can see in the image, we have the ecological framework and briefs in each of the levels of the ecological framework. For some those of you who are familiar with the framework, so the inner circle is the individual level, then the middle circle is the interpersonal level, and then the outer circle is more the community level. So at the individual level, we have this brief focusing on strengthening individual knowledge, attitudes, beliefs, and self-efficacy. Then we have at the interpersonal level promoting couple communication. And at the norms level, we have the social norms brief at the community level. And again, that's the main focus of our conversation today. Let's go to the next slide, please. Okay, so in the next two slides, I will cover very briefly some tips, general tips for implementing SBC programs, and then we will move on to discuss the norms brief. So a critical piece, and this is when you go to behavioral sciences graduate school, first thing you learn is that you need to do formative research. You must do formative research. And sometimes it's hard to have the funding to do formative research. In those cases, you could use a shortcut potentially, such as looking at the literature and seeing what others have found in the topic that you're looking into. But it's very critical that you collect some formative research information. And what is this formative research? It's information that really gives you a sense of what's happening on the ground in your community, in your region, for the topic that you want to address. The next tip is about the importance of pre-testing materials to make sure that you have not missed anything important. And I'll give you a funny example there. I was working with some students who were developing a screening tool here in the area where I live in Montgomery County, and how some folks here abbreviate Montgomery County is MOCO, MOCO, and the materials were for Latinos in this area, folks from Latin American continent. And in Spanish, MOCO reads moco, and that means booger. So, we didn't want to use that word in our material. So they pretested them, found that people were chuckling, and realized, no, this is not going to work. So just a funny example to show time and time again the importance of pretesting materials. Then another important point, selecting your channel, the best channel to reach your audience, or the best method, if it's not just communication. And then also very important to work with existing community groups. Moving on, another important tip is segmenting your audience, because you want to make sure that the methodologies that you're using are going to reach them. What you may use to reach adults may not be suitable to reach young people. So very important to think about your audience. And then also very important to intentionally incorporate equity into your program. This means that you need to try not to leave anyone behind. And these typically vulnerable groups that historically have been marginalized are often forgotten. Oftentimes, we need to do a little bit more to reach them and make sure that they're getting the information that they need. And then finally, you want to make sure to collect the data to have a robust M&E system in place to collect data that you will use to inform your program and make adjustments. This is critical, and this is something that I think we're doing more and more in our area in terms of adjusting the program based on what we're learning. So continuous adjustment. So let's go to slide 18. Oh, these are just very briefly some tools that you can see in the brief and that you can access to learn how to design and implement behavioral interventions for family planning, or behavioral interventions in general. Okay, let's go to the next slide, please. Great. Thank you very much. So with that, and again, we wish Joanna prompt recovery. Let's now go on to our, again, main course of the day, the norms brief. It is my pleasure to introduce Rebecca Lundgren. She has nearly 30 years of experience designing, implementing, managing, and evaluating sexual and reproductive health and behavior change programs. Currently, Rebecca leads Agency for All, which is a USAID-funded research project aiming to understand, develop local understandings and measurements of this construct of agency. So with that introduction, I pass the floor to you, Rebecca. Thank you for being here with us today.
Thank you, Maria. Thanks for going over the implementation tips. It struck me, listening to you talk about them, how relevant they are for the social norms work, as well as all the other kinds of SBC work we do. So hello, everyone. I'm really excited and pleased to introduce you to the Social Norms Brief. It's really an honor to present the work that our team did together with the HIPTAG and writers on this product. Next, please. In some ways, the most difficult part of our work was defining the practice. There's been and still is, I think, a lack of clarity about what exactly a social norms program or intervention is. The definition you see here is broad: interventions that address social norms to support an individual or couple's decision-making power to meet their reproductive intentions. So you might ask, why are we using the word address here rather than, for example, change norms? That's because efforts to address harmful norms may seek to change them, or they might simply seek to mitigate their effects. Social norms interventions could also seek to foster positive social norms. So that's why we tend to talk about, addressing norms rather than shifting or changing them. Next, please. So an individual or couple's decisions and behaviors around contraception are influenced not only by their individual knowledge, beliefs, and attitudes, but also by those informal and mostly unwritten rules of communication, rules that communities have where they live that we call social norms. So I think, as many of you know, social norms are not the same as attitudes. Attitudes are internally driven. They're more what I believe, while norms are externally driven, what others expect of me, specifically my behavior. I find it easiest to distinguish a social norm from an attitude by thinking about it this way. Social norm is what people believe is typical. So maybe how my friends, for example, expect me, how my friends dress, or what others expect. So maybe what kind of praise or criticism I get for the way I dress. So that's typically called injunctive and descriptive norms. The labels are not so important, but I think about, what do other people do and what do they expect that I do? And those would be two elements of a social norm. Next slide, please. So social norms are sustained and enforced by the people whose opinions matter to us. That might be your partner, your friends, your family, community leaders. Individuals who don't act in accordance with social norms might face sanctions, so they might be ostracized, criticized, lose status because they're breaking norms, or they could also be rewarded by conforming to norms. So basically, we think about sanctions, both positive or negative, which is what enforces norms. Next slide, please. Interventions that address social norms typically do one or more of the actions that you see here on the slide. So they might identify the social norms in reference groups. That's very analogous to what Maria was talking about in terms of formative research. That's important before you begin a behavior change program. Very importantly, they seek change at the community rather than the individual level. So I'm always reminding people, if you're trying to shift norms, you're probably not the best idea is not to focus just on those people who want to change, because they may not have the power or ability to change those social norms. They may be more affected by their reference group and the society around them that is enforcing the norms that they need to follow. Social norms interventions also typically confront power imbalances, for example, those related to gender, age, or other kinds of social hierarchies. And they often create or reinforce positive norms to help to support healthy behaviors. Next slide, please. So every HIP has a theory of change, and here you see our theory of change. So this high impact practice addresses social norms related to communication about contraception, gender inequities, and lack of agency to make reproductive health decisions. Specifically, a social norms intervention aims to increase the acceptability of talking about contraception and using contraception, as well as the agency to make reproductive health decisions. So our expected outcomes of this type of program would include increased couple communication, adolescents seeking contraceptive methods, contraceptive use, and gender equality. All of this with the goal or impact of helping women and men achieve their fertility intentions. Next slide. So it's very important to address social norms because they often play a critical role in preventing women and men from acting on their reproductive intentions. It's also typically, not as much now, but traditionally been one of those elements that social and behavior change programs didn't tackle or left aside or felt were too difficult to address. So evidence shows us that social norms have an effect on couple communication about contraception, decisions about when to have a child, how many children to have, contraceptive use, and all of the pieces about that go into effectively using a contraceptive method and accessing healthcare. Next slide. So let's talk for a little bit about what interventions do address social norms. The HIP team reviewed published and gray literature to identify social norms interventions with evidence of effectiveness. So one of the challenges we faced was finding literature that had evidence both on whether the norm was shifted and whether contraceptive use was improved. So there's a lot of programs out there, of course, that shift contraceptive use and probably do affect norms, but there's no norms measure. And less so, there's some programs out there that show that the norm was shifted, but not contraceptive use. So what we sought here was the Holy Grail, doing the two things, evidence that it did both things. So the team found 6 family planning interventions, which were implemented in diverse settings, from Benin, Niger, Zambia, Kenya, Nigeria, and Palestine. Most use multiple components to address different levels of the socio-ecological system. Now I think there are more out there because there's been improvements in measurement, more attention to social norms, but at the time we did the review, those were the ones that we found. They specifically included the mechanisms that you see on the slide, multiple channels of communication, some sort of reflective dialogue, either at the couple or community level, mass media, interpersonal communication, and social media. Not only one of those, but I think there are more out there now. Next slide. So as I mentioned before, many demand or social and behavior change efforts focus on improving knowledge and attitudes, but they overlook the social barriers to people acting on their desire to space birth. One of the programs included in the HIP, Tekpon Jikwagu, or TJ as we call it, took a different approach. In Benin, TJ worked through social connections to reduce the barriers that lead to unmet need for contraception. So when we were working on it, we really found that people just didn't feel permission to talk about or to use contraception. So the program was designed to give people permission to do those things. It used social mapping to identify key influencers, reflective dialogues, community radio, and specific encouragement for influencers to talk about family planning. This led to effects on both social norms and contraceptive use. So for example, men who heard the radio broadcasts were more likely to believe that their peers use contraception, making them more confident that they could do so themselves. Men and women who participated in the reflective dialogues were also more likely to believe that their peers approved of family planning. So that was really addressing that injunctive norm that I mentioned before, what people expect of you. And the percentage of women who were using a contraceptive method increased significantly. I think Mariam will talk a little bit more about TJ so you can understand more about how the program was implemented. And let's move next to talking about implementation measurement. So improved measurement would definitely result in better program guidance for social norms work. Here you see some illustrative indicators to assess social norms interventions that are included in the brief. These include the core elements of what we're beginning to think of as core of gold standard social norms measures. They cover descriptive norms, what others might do, injunctive norms, what others think I should do, and diffusion, and they specifically include the reference group, which is the body or the mechanism by which social norms are created, passed on, and enforced. So as written, these indicators would be measured by surveys, but of course they could be adapted for use in different kinds of qualitative methods as well. So there are now many resources available to support your work on social norms. On this slide, you see a number of them, and I think there'll be a handout with many more. So you see on the left the 20 essential resources on social norms and family planning. That's a compilation of useful resources. The Social Norms Exploration Tool is a resource for conducting that formative research, a rapid exploration of social norms and reference groups related to a specific behavior. It's been used in over 60 initiatives globally to inform program design and monitoring and evaluation. Then you see Getting Practical, which is a tool to really address that gap between now you know about norms and reference groups, but how do you put it into program design? Then we see a taxonomy, which gives a simple classification system for social norms related to family planning. It's really useful if you want to just get a better understanding of what exactly is a social norm and what norms should I be on the lookout for. And finally, you see the Social Analysis and Action Implementation Guide produced by CARE, which provides a facilitated process for helping individuals explore and challenge social norms. Next slide. If you'd like to learn more about social norms or exchange ideas with others grappling with issues related to social norm shifting approaches, monitoring and evaluation of those programs, you can visit the Align platform. At this site, you can browse many materials that were produced by the Global Learning Collaborative, and you can also join one of the Social Norms Learning Collaboratives. So these are basically communities of practice on social norms in Nigeria, Eastern Africa, Francophone Africa, South Asia, and the one for those of us who work globally without a specific regional focus. I think that's all. And with that, I'd just like to thank you very much for your time and maybe turn the floor over to, I'm not sure if Maria or Mariam goes next.
Thank you so much, Rebecca. Thank you so much for that excellent presentation. I will go next briefly to present our next speaker, Mariam Diakité. Mariam is from Mali and based in Bamako. She has more than 10 years of experience in research and program evaluation. And she has worked in programs to address social norms related to gender-based violence and also has expertise working with NGOs based in Mali, Benin, Senegal, Niger, Cote d'Ivoire, Burkina Faso, Djibouti, and the Democratic Republic of Congo, DRC. So with that introduction, I pass the floor over to Mariam. Thank you so much for being here, Mariam. Please go ahead.
Okay. Thank you, Maria. Hi, everybody. I would like to present our experience with a norm shift intervention called Tekpono Jikwagu. I will use also TJ for the same name. Next, please. So Tekpono Jikwagu is a USAID founding norm shift intervention to address low modern family planning uptake. So the approach was implemented in Benin by the consortium led by IREC, Institute for Reproductive Health. So next, please. So before presenting TG, I would like to focus on a learning collaborative. It is a community of practice for Francophone Africa. So we have a group of experts, programmers, researchers, and also decision makers who are reflecting on social norms. So they are intervening in Francophone Africa area. So I would like to share these links to have more information, more resources, and also if you would like to join, to use the link. will be welcome. Next, please. So in the social norm domains, what I would like to say, it's so important to gather multi-experts because social norm is complex and also its change, its difference in space. So for that reason, a learning collaborative member did a social norm intervention mapping in 10 countries in Francophone area, in West Africa, Central one, and East Africa. So we found four social norm common on these 10 countries. As you can see, we examined 100 of 29 normative intervention, and we found these four norm in the countries. It is gender norms, child marriage, female genital mutilation, and sexual reproductive health included family planning. So during our examination, we found that gender norms are the most frequent, followed by sexual and reproductive health, including family planning, but norms relating to marriage, child marriage, and female genital mutilation was low. So what we noticed that most of the time, gender is transversal, even if we decide to focus on sexual reproductive health, for example, we will focus some time on gender issue, and mostly the decision maker, most of the time men is the central decision maker, and the woman does not have the decision power. Next, please. So I'm come to TJ, Tekpono Kwagu, that is a Beninese name, but when we do the scale up, I will talk about it. We name it Perikunda Jekulu. So the context is that there are an increase of family planning and met need in West Africa despite of investment. Okay, thank you. And several social factors contribute to unmet needs, like fertility and family planning decisions are rarely individual. Rather, they are influential by social network and social norm. That means intervention need to focus and address the community member rather than the individual alone. So what did he do by using multiple strategies? Next, please. So here we have some norms addressing by TG. Many of the norms had been identified by a research that had been carried out to identify different factors. For example, we have community belief that religion prohibits use of FP, result in stigmatization, lack of support in the community, and disapproval of family planning use. Also, as I said, we have the decisions are influenced by the people with whom we interact. Like couple decisions are influenced, for example, by a mother-in-law or by a friend or a sister. We have men who are the final decision maker. So men don't communicate with his wife, so they miss the couple communication, and also parents don't communicate with child because in this community, the communication on sexuality is taboo. Also, having many children value men and women. Most of the time, when a couple get married, the first thing people expect for them is to get a child as soon as possible. Next, please. So to develop the intervention component, the research findings were used so to identify the main factors that influence the behavior. So for that, we use a participatory method in use of mapping, community change, agent, and reference group. So you have the 5 components on my right, on my left, sorry. So we use of multiple level gender synchronized program strategy to bring social behavior. Also a community approach using social networks and social and behavior change communication implemented by socially influential community members, and communication material are easy and simple to use. So it's adjustable to different contexts. For the communication materials, we use also the research finding so that this material can reflect in the reality of the community. That means it is the stories or activities that reflect on the reality, and also we use factors that we found in the research to make our communication materials. For example, we use also the characters in the story. The character is used seems to be reality. For example, when we found that the decision of family planning is influenced by a mother-in-law, so we use a mother-in-law as one character, play a role of position decision maker, or a sister to advise, or some friend, etc. Next, please. Here we have a strategy we use for norm shift strategy. At individual level, we train change agents. For that, we train some NGO staff who facilitate, who coach the community member involved in the approach in the intervention. For example, we train community NGO member because they need to be comfortable with some concept like gender concept, like social and behavior change approach, something like that. And then they are trained to train, like trainer to train community members who are going to implement the activities, because in the community, the activities are implemented by the community member too. For that, a participatory method is used to select this change agent and reference group that catalyze the discussion and reflection on social and gender barrier of family planning use. So story and activities used reflect on community reality, as I say. So for that, they are training to use material and how to communicate, because in the community, it's sometimes hard to come to use some strong word. For example, sexuality is a taboo. So it's difficult to come to use the word sexuality. You can find in the community they use another manner to refer to the sexuality. For example, in some community they can use to have bed. To have bed is most acceptable than they have intercourse between men and women. And also we have interpersonal strategy that engage socially influential groups and opinion leaders. For that leader, we can have religious leader, community leaders of youth people, or teacher, health worker, etc. Most of the time, these leaders are informal. So also these influence people and group are diffuse ideas in show support for FP user, because as you know, it is something which is not discussed. But with the approach, it encourages people to discuss between couple, between friends, and diffuse in their family, so and so off. And then there are community strategy that engage the government to support and legitimize the intervention. Also, we have the campaign we call Each One Invite Three, that is to make a diffusion abroad, like a radio broadcast too. And at the end, there are a closing ceremony to, TG approach, the community people who are engaged are not paid. They do that voluntarily. So to encourage them at the end of the implementation, because it doesn't take long time. We experimented it in nine months and it works. So it is to encourage them by certificate them to recognize their work. Next, please. So to most discover TG, I would like to invite you to watch a short video on the TG components.
Le paquet d'intervention de TG a 5 composantes. La première composante, c'est la cartographie communautaire. Donc, on va dans la communauté avec les membres de la communauté. On identifie des groupements de femmes et d'hommes influents. De plus, des personnes influentes. Ces personnes peuvent être des leaders religieux, comme des femmes d'association ou d'autres. La deuxième composante, c'est le dialogue et réflexion au sein des groupements influents. Les groupements sélectionnés vont désigner un de leurs membres. Ces membres sont formés à utiliser les matériels de communication qui sont des histoires et des cartes d'activité qui suscitent des discussions sur les facteurs de barrières socio-culturelles qui empêchent les femmes et les hommes d'utiliser les méthodes modernes de planification familiale. À la suite des discussions, les participants diffusent les nouvelles idées dans leur réseau. La composante 3, c'est l'engagement des personnes influentes. Les femmes et les hommes identifiés dans la composante 1 vont décider de mener des activités qui sont convenables. Ainsi, elles vont appuyer les interventions dans leur communauté. La composante 4, c'est la diffusion à travers la radio communautaire. Les discussions menées par les groupements influents sont diffusées à travers les radios communautaires qui sont basées dans la communauté afin de toucher plus de personnes. Enfin, la composante 5, c'est de créer un lien entre la communauté et les services de santé. Au cours des discussions des groupements influents, les agents de santé sont invités pour répondre aux questions techniques liées à l'utilisation de l'APF. De plus, il y a la campagne Chacun invite 3. On distribue des cartes d'invitation afin que les gens discutent sur l'APF et les encourager à visiter les services de santé afin d'avoir plus d'informations et d'utiliser des méthodes modernes de PF.
Le projet TIGI a connu des résultats marquants au Mali et au Bénin.
Le projet TIGI a apporté beaucoup de changements chez nous, ici dans le village de Balan. Beaucoup de changements dans beaucoup de domaines. Des domaines comme l'espacement des naissances, par exemple, ou bien la réduction des frais d'ordonnance.
À la base, l'approche TIGI a été conçue avec la mise à échelle en tête. C'est un paquet d'interventions qui est facile à intégrer. Dans notre expérience au Bénin aussi bien qu'au Mali, les partenaires l'ont facilement intégré et aussi ça a renforcé leur programme, que ce soit le programme de santé ou de développement. Au niveau communautaire, ça a amélioré la communication au sein des couples et le soutien de la communauté en faveur de l'utilisation des méthodes modernes de planification familiale.
Thank you so much. Next slide. So as you saw, we adapt the intervention package to Malian context. For that, we didn't need to do many adaptation. We just change the name of characters and also some phrases. As I said, there are some things we can say it's not check in a community, but in other community it's check. One of the example is that to see men doing the course halls is most acceptable in Benin than in Mali. So we just change this kind of scenario. So many NGO had implement integrated TG in their project, ongoing project like nutrition project, educational project, and sexual and reproductive health of adolescent one, and we found the same result. Sometimes we have exactly the same result in Benin as in Mali. So that shows that this intervention, when we adapt it, we have some result. And we did a impact research, post-intervention evaluation, and we found that the impact out the effect was sustainable. And we found also, even if we didn't directly target the adolescent, but we found that the mother were engaged the adolescent and youth girls to hear about TG and also to use family planning. Next. I invite you to visit this site to have more information about TG, called Technology Kwabu in Benin, Terikunda Jekulu in Mali, and another name somewhere else I don't know. So thank you for your attention.
Excellent. Thank you very much, Mariam. And now we're moving on to the last 15 minutes or so of our webinar for our questions and answers section. So please don't forget to write your questions on the question Q&A section of the platform, which you will find on the right side of your screen. So let's start with some of the questions. So we have a question from Sarah Osman, who's asking if there was always signposts, referral to services through the dialogue, radios, etc. in the TJ intervention. If this could be answered maybe by Rebecca or Mariam.
Yeah, I can go ahead and answer that. Yes, so there was, like in any sort of social norms program that I've participated in, there's also some sort of parallel effort to make sure that the services are good quality and accessible. So even though our focus was on the normative piece, of course, you can raise demand and get people to go to, but if there's no services, then you won't have an impact. Of course, it's very challenging, and it was challenging in Benin with TJ, but there were both efforts to sort of strengthen working with local partners, the services, and also there was a referral coupon in TJ. It wasn't like for free services, but it was called Each One Invites Three. So we gave people the card so they would invite people and go to services. And sometimes they did go. Sometimes they went in groups, which kind of overwhelmed the service delivery system. So that didn't work out as well as you would think. You get people feel comfortable going together in a group, but then there was challenges on the other end. But in short, yes, there's usually some sort of service, definitely referrals, if not, other system strengthening pieces that are needed.
Great. Thank you very much, Rebecca. Let's move to another question to make sure we answer as many of them as possible. This question is from Praise Musinga, and she's asking, how have the projects managed group dynamics, and have they been able to be a unit and keep together the group members for the whole project life?
That would be a better question for Mariam, I think.
So Mariam, if you can comment on this one.
Yes, great. Yes, to identify the groups, we didn't create a new one. We did a mapping to select the existing groups. For that, we involve the community member so that they can be socially representative. For example, we invite women leader, youth leader, isolate people, the chief of village, or the health worker, a teacher, some people that can represent the culture of the community, and then they list a main group, influential group existing in this community. And after that, we have some criteria. We use this criteria to identify the most influential, and with the participant, we try to select, it depends on the size of the village, we can select 3 groups or to 6 groups. And for this group, we identify both men groups and women groups, and also youth one if they existing in the village. If not, we complete with the mixed groups. So for that, as it is a existing groups, TG or not TG, these groups are gathering regularly, and we don't invite them to gathering except for TG activities. They do TG activities with the normal activities. For example, if it is a group of saving group, if they have to gather every first day afternoon, so during their meeting, they select one time to discuss on TG. And for that, it's not the NGO member who comes to animate the discussion. It is one of the members, they own select to be the catalyzer. It is a the person who catalyze the discussion with the TG materials. So this person animates the discussion. It doesn't take long time, and they try to discuss, because after the story, there are some questions that have asked to people. So they answer the question, if it is you at this context, what are you doing? People try to answer in their perception, and then this creates a kind of discussion on family planning and also other factors like couple communication or how to behavior their money factor like that. So that is, even when we did the post-evaluation, we found that groups are going to working, and there are some groups who reinvent other activities, because after using all the materials of TG, they will like to continue because they find it very attractive and help them, the couple, to improve. So some identify, for example, the domicile, to go to the household and try to discuss of people, or some create other activities, but always around the family planning and other barrier that prevent them to use family planning
Great.
method.
Thank you, Mariam. So let's move. We have quite a few questions, so let's try to get to as many as possible. The next question is from Bev Johnston. She says, "Thank you, everyone, for the presentation. Could you comment on embedding implementation science in TJ and other SBC interventions?" So I'll pass this one to Rebecca.
Yeah, so these were implementation science. This was an implementation science project. So, we began with social network research to kind of inform the intervention, some qualitative work, some quantitative work. And well, Mariam, for example, was very engaged with, she was our monitoring and evaluation officer, but I was also there to make sure that sort of the implementation, monitoring, and evaluation teams work together seamlessly to learn along the way and improve the intervention. You sort of use responsive feedback and improve and guide what we were doing all along the way. So I think that marriage of, or that implementation research approach is what ultimately made the project successful.
Excellent. Thank you so much, Rebecca. This next question is from Saswati Das, and this is very similar to a question from Praise Musinga as well, her second question. So Saswati is asking, what was the impact of TJ on the TJ project on modern contraceptive prevalence, or I will add any other family planning outcomes? Could it be measured? And Praise is asking, how did you measure your results? And she notes that it's actually it's difficult to measure results of, especially, for example, through radio or talk shows, or how are you documenting results of norms interventions? So Rebecca and then Mariam.
Yeah, sure. So, I mean, we had a number of measures, but the most important one was our survey. So we had a baseline and inline survey. It was a quasi-experimental design. So we were able to compare, differences in contraceptive use and on social norms, baseline, inline, and comparing with our control group. So we did find significant increases in contraceptive use. So I think I share the little piece of that the percentage of women and men using contraception doubled in less than a year. And then we also, in our survey, we had a lot of questions about exposure to the intervention, so we could tease out, whether it was the radio or whether it was being exposed to multiple pieces of it. We didn't have the resources to do a multiple arm trial, but we did tease out some of those like specific intervention component results. And you can read, if you go to that link that Mariam shared, you can read the final report and read a lot more about the measures that we used to evaluate its success. There were, just worth noting that we did interviews with men and women, and the results were, we had significant positive effects with both, but they were somewhat different. The channels that affected them were different, some of the results were different. So it's a good reminder that, the way men and women change and the way we reach them can be different and needs to be tailored.
Excellent. Thank you, Rebecca. Mariam, do you want to comment on this monitoring and evaluation, and your experience of monitoring and evaluation of SBC programs, specifically
Yes,
TJ?
sure.
Thank you.
Yeah. For the Radio 1, we had some indicator because during the Radio 1, we had a broadcast called which people call and interact, comment the story of TG. For that, the DG note on the forms the number of person who calls and what was the intervention. That helped us to know if many people calls or no. And the result was that we found that many men calls than women during this intervention. But when we took the data of evaluation, we found that women also use radio, but they don't have enough means to call. For the monetary data at the health centers, for example, during the campaign, each one invite 3. We follow up the invitation card at the center. So the wife, the health worker, we give them a forms. They have to tick if people come with a card. And after, at the end of each month, we go back to collect the invitation card. And at the back of the card, they note if the person have used the method, which method, if it was for information, which one. It was one person, a couple, or a group. So the health worker marked it, and then we analyze data to see if people is going. That help us to know that at the beginning, many people didn't go to this health center. So we readapt the campaign to push so that we can have many people. And at the end, we have many people who had visited the health center to make sure that TG has contributed to the increase. We also did analyze the secondary data at the time before TG and during TG. in the control area and intervention area. And we saw that in the intervention area, we noticed an increase. Even if we had increase in the control area, but TG1 was more increased than the, control area.
Thank you very much, Mariam. Very helpful. Let's move to, it looks like we may have time for one more question. There's a question about male involvement and whether there are any tips and clues to share in terms of whether male men were involved in the study. And just before I pass it on the floor to the speakers, just to note, we do have an SPG on male engagement strategic planning guide on the HIPS website that can give you some ideas. But very briefly, maybe Rebecca, we have 30 seconds because we're at time. Any clues on how to better engage men?
Clues. So first of all, it's important to understand, what their motivation and barriers are, and, and kind of frame the program so that it addresses their needs, not just do this on behalf of women. So definitely understanding, what norms their behaviors are shaped by and who is their reference group. And maybe pertinent is that we have found in a number of social norms programs that men and women sometimes are influenced by injunctive versus descriptive norms. So there can be differences in what kind of norms influence men versus women. And also their reference groups are different. So it's really important when you're working on a social norms program to understand, go back to that understanding of what are the norms and what are the reference groups that influence the behavior that you're interested in for men and for women, if you're looking at, couple things.
Excellent. Thank you so much, Rebecca. And we're going to have it to end our webinar. We're at time. So before we close, I want to share the hyperlink of today's presentation and recording. For more information on the SBC or to get a copy, briefs or to get a copy, please go to the HIPS website. Thank you so much for joining today. And thank you very much to the panelists and also Ados May from the IBP Network who organized the webinar today. And again, thank you so much for being with us today and have a good rest of your days. Take care. Bye-bye.